Good morning, everyone. The topic that I'm going to present to you is all about thrombosis risk factors. Acquired thrombosis risk factors. In life, we acquire a legion of habits and circumstances that either help maintain or damage our hemostasis system. Their variety and interplay make it difficult to pinpoint the factors that contribute to thrombosis or to determine which have the greatest influence. This factor seems to contribute to venous and arterial thrombosis in varying degrees. Table 39.1 lists the non-disease lifestyle risk factors implicated in thrombosis. Non-disease lifestyle factors that contribute to thrombosis. Risk factor. AIDS. Comment. Thrombosis after age 50. Contribution to thrombosis. Risk double each decade after 50. Immobilization. Sedentary, distance driving, air travel, restriction to wheelchair or bed, obesity. Contribution to thrombosis. Showed blood flow raises thrombosis risk. Diet, fatty foods, inadequate folate, vitamin B6, vitamin B12. Contribution to thrombosis. Homocystinemia associated with 2 times to 7 times increased risk for arterial or venous thrombosis. Laboratory diagnosis, plasma homocysteine, vitamin levels, and lipid profile. Lipid metabolism imbalance, hyperlipidemia, hypercholesterolemia, dyslipidemia, elevated lipoprotein A, elevated triglycerides, decreased HDL-C, elevated LDL-C. Contribution to thrombosis, moderate arterial thrombosis association with LDL-C elevation and hypercholesterolemia may be congenital. Laboratory diagnosis, lipid profile, total cholesterol, HDL-C, LDL-C, triglycerides, and lipoprotein A. Oral contraceptive use, 30 microgram formulated with progesterone. Contribution to thrombosis, 4 times to 6 times increase. Pregnancy. Contribution to thrombosis, 3 times to 5 times increased risk. Hormone replacement therapy. Contribution to thrombosis, 2 times to 4 times increased risk. Femoral or tibial fracture. Contribution to thrombosis, 80% incidence of thrombosis if not treated with antithrombotic. Hip, knee, gynecologic prostate surgery. Contribution to thrombosis, 50% incidence of thrombosis if not treated with antithrombotic. Smoking. Contribution to thrombosis depends on degree. Laboratory diagnosis, HSCRP or high sensitivity C-reactive protein. Inflammation, chronic. Contribution to thrombosis, arterial thrombosis. Laboratory diagnosis, HSCRP. Central venous catheter. Endothelial injury and activation. Contribution to thrombosis, 33% of children with central venous line develop venous thrombosis. Thrombosis risk factors associated with systemic disease. Several conditions and diseases treated as with thrombosis. Some listed in Table 39.2 with an indication of laboratory's diagnostic contribution. Transient and chronic antiphospholipid antibodies, such as LAC, anti-cardiolipin autoantibodies, and anti-B2 glycoprotein 1 autoantibodies may be detected in 1% to 2% of the unselected population. Chronic APLA confirm a risk of venous or arterial thrombosis, a condition called antiphospholipid syndrome. Often accompany autoimmune connective tissue disorders such as lupus erythematosus, Some appear in patients without any apparent primary disorder. Malignancies often are implicated in venous thrombosis, tumor production of tissue factor analogs that trigger chronic low-grade PIC. Venous and arterial stasis and inflammatory effects raises the risk of thrombosis. Migratory thrombophlebitis or Trousseau syndrome is a sign of occult adenocarcinoma such as cancer of the pancreas and colon. Myoproliferative neoplasms such as essential thrombocythemia and polycythemia vera may trigger thrombosis, probably through platelet hyperactivity. DIC, a cardinal sign of acute promyelocytic leukemia, is a secondary to release of procoagulant granule contents from malignant promyelocytes. May intensify during therapy at the time of vigorous cell lysis. Paroxysmal nocturnal hemoglobinuria is caused by a stem cell mutation that modifies member-anchored platelet activation suppressors. Venous or arterial thrombosis occurs in at least 40% of PNH cases. Chronic inflammatory disease causes thrombosis through a variety of mechanisms such as elevation of fibrinogen and factor VIII, suppressed fibrinolysis, promotion of arteriosclerotic plaque formation, and reduced free protein S activity secondary to raise C4b binding protein levels. Diabetes mellitus is a particularly dangerous chronic inflammatory condition, raising the risk of cardiovascular disease sixfold. Conditions associated with venous stasis, congestive heart failure, are also risk factor venous thrombosis. Untreated atrial fibrillation increases the risk of ischemic strokes caused by clot formation in the right atrium and immobilization to the brain. Nephrotic syndrome creates protein imbalances that leads to thrombosis through loss of plasma proteins such as antithrombin. It may also be associated with hemorrhage. Disease with thrombotic risk components. Antiphospholipid syndrome, effect or example. Chronic antiphospholipid antibody, often secondary to autoimmune disorders. Contribution to thrombosis. When chronic, 1.6 times to 3.2 times increased risk of stroke, myocardial infarction, recurrent spontaneous abortion, venous thrombosis. Laboratory diagnosis, PTT mixing slides, locus anticoagulant profile, anticardiolipin antibody, and anti-B2 glycoprotein 1 immunoassays. Myoproliferative neoplasms. Examples are effects: essential thrombocythemia, polycythemia vera, chronic myelogenous leukemia. Contributions to thrombosis, increased risk as a result of viscosity platelet activation. Laboratory diagnosis, platelet counts and platelet aggregometry. Hepatic disease. Example or effects: diminished production of most coagulation control proteins. Contribution to thrombosis, increased risk as a result of damaged coagulation pathways, excess thrombin production, reduced fibrinolysis. Laboratory diagnosis, PT, protein C and S, and antithrombin assays, factor assays. Cancer adenocarcinoma, Trousseau syndrome, low-grade chronic DIC. Contribution to thrombosis, 20 times increased risk thrombosis, 10% to 20% of people with idiopathic venous thrombosis have cancer. Laboratory diagnosis, DIC profile, platelet count, D-dimer, PTT-PT, fibrinogen, blood film examination. Leukemia. Example, LARIPEX, acute promyelocytic leukemia, acute monocytic leukemia. Contribution to thrombosis, increased risk of chronic DIC. Laboratory diagnosis, DIC profile. Platelet count, D-dimer, PTT, PT, fibrinogen, blood film examination. Paroxysmal nocturnal hemoglobinuria. Example or effects, platelet-related thrombosis. Contribution to thrombosis, increased risk for deep vein thrombosis. Pulmonary embolism, DIC. Laboratory diagnosis, flow cytometry, phenotyping for CD55 and CD59, DIC profile. The platelet count, D-dimer, PTT, PT, fibrinogen, and blood film examination. Chronic inflammation. Example or effect, diabetes, cancer, infection, autoimmune disorder, obesity, smoking. Congenital thrombosis risk factors. Congenital thrombophilia, when thrombotic event occurs in young adults, occurs in unusual sites such as the mesenteric, renal, or axillary veins, is current, or occurs in a patient with a family history of thrombosis. Because thrombosis is multifactorial, even patients with congenital thrombophilia are most likely to experience thrombotic events because of the combination of constitutional and acquired condition. Antithrombin activity assay, previously called antithrombin 3 or AT3 assay, has been available since 1972, and protein C and protein S activity assays became available in mid-1980s. The 1990s brought the APC resistance assay and its confirmatory FBL mutation molecular assay, the prothrombin G210A mutation molecular assay, and more recently tests for polymorphism in factors 8 and 11 genes, dysprenogenemia, plasminogen deficiency, plasma TPA, and plasma plasminogen activator inhibitor 1. Homocystinemia is associated with inadequate dietary folate, vitamin B6 or vitamin B12, and with polymorphisms affected the function of methylene tetrahydrofolate reductase in methionine metabolic pathway. Folate supplementation in industrialized countries has reduced the incidence of homocystinemia. Although methylene tetrahydrofolate reductase polymorphisms are associated with homocystinemia, they do not correlate with incidence of arterial thrombosis. Efforts to reduce plasma homocysteine concentration do not reduce the risk of arterial thrombosis. APC resistance found in 3% to 8% of Caucasians worldwide. APC resistance extends to Arab and Hispanic populations, but mutation is nearly absent from African and East Asian populations. APC resistance may exist in the absence of the FVL mutation and is occasionally acquired in pregnancy or in association with oral contraceptive therapy. FVL gene mutation is the most common inherited thrombosis risk factor, whereas prothrombin G2021-0A gene mutation is the second most common inherited thrombophilia in patients with a personal and a family history of deep vein thrombosis. Protein C, protein S, and antithrombin deficiencies are found only 0.2 to 1% of the world population. Predisposing congenital factors and thrombosis risk. Antithrombin deficiency. Function. Antithrombin enhanced by heparin exhibits serine proteases 2A, 9A, 10A, 11A. Thrombosis relative risk. Heterozygous 10 times to 20 times. Homozygous 100% rarely reported. Unselected population 1 in 2 to 5,000. Thrombotic event 1% to 8%. Laboratory assays clot-based and chromogenic antithrombin activity. Antithrombin concentration by immunoassay. Protein C deficiency functions. Activated protein C is a serine protease that hydrolyzes factors 5A and 8A, requires protein S as a stabilizing cofactor. Thrombosis relative risk. Heterozygous 2 times to 5 times. Homozygous 100% neonatal purpura fulminans. Unselected population 1 in 300. Thrombotic event 2.5% to 5%. Laboratory assays clot-based and chromogenic protein C activity. Protein C concentration by immunoassay. Free protein S deficiency. Protein S is a stabilizing cofactor for activated protein C. 40% free, 60% circulates bound to C4b BP. Heterozygous 1.6 times to 11.5 times. Homozygous 100% but rarely reported neonatal purpura fulminans. Unselected population is unknown. Thrombotic event 2.5% to 5%. Laboratory assays clot-based free protein S activity assays. Protein S concentration by free and total immunoassays. APC resistance. Function factor V laden R56Q. Mutation gain of function renders factor V resistance to APC. Thrombosis relative risk heterozygous 3 times, homozygous 18 times. Unselected population 3% to 8% of Caucasians, rare in Asians and Africans. Thrombotic events 20% to 25%. Laboratory assays, PTTBs, APC, resistance test, and confirmatory molecular assay. Prothrombin G2021-0A. Mutation in prothrombin gene untranslated 3' promoter region, moderate prothrombin activity elevation. Thrombosis relative risk heterozygous 1.6 times to 11.5 times. Unselected population 2% to 3% of Caucasians, rare in Asians and Africans. Thrombotic events 4% to 8%. Laboratory assays, molecular assay only. Phenotyping assay provides no specificity. Homocystinemia. Function associated with arterial thrombosis. Thrombosis relative risk males 4.3 to 9.9 molecular millimoles per liter. Females 3.3 to 7.2 millimoles per liter. Folate, vitamin 6, vitamin B6, vitamin B12 deficiency, MTHFR, C677T, and A1298C polymorphisms. Prevalence. Folate supplementation reduces prevalence. MTHFR polymorphisms are not a risk factor for arterial thrombosis in folate supplementation. Laboratory assays, fluorescence polarization immunoassay. Hyperfibrinogenemia, function associated with arterial thrombosis. Thrombosis relative risk, acute phase reactant. Laboratory assays, close fibrinogen, clotting assay, immunoassay, nephelometric assay. Thrombosis double hit. Thrombosis often associated with a combination of genetic defect, disease, and lifestyle influences. Just because someone possesses antithrombin, protein C, protein S deficiency does not mean that thrombosis is inevitable. Many heterozygotes experience no thrombotic event during their lifetimes, whereas others experience clotting only when two or more risk factors converge. A woman who is heterozygous for the FBL3 mutation has a 35-fold increase in thrombosis risk when using oral contraceptives. Homocystinemia tripled the risk of idiopathic venous thrombosis, and the FBL mutation doubled it. Those with multiple congenital thrombotic risk factors coupled with homocystinemia experience increased thrombosis risk.